Okay, Mr. Stevens, I'm just going to give you a quick test here, all right? I'm going to touch your hand with this, and you tell me whether it feels sharp or dull.
Why am I here?
You're in the hospital. I said we're just going to give you a little quick test, okay? Does that feel sharp or dull?
Mary left yesterday.
Mr. Stevens, you're in the hospital with me, okay? We're just taking a quick look at you, and I just want to know whether this feels sharp or dull.
Oh, is that Mary?
Mr. Stevens, can you work with me for 1 second, please? Can you look, sir, can you look at me?
Where am I?
You're in the hospital, sir. I just told you that. All right? Can you look at me for a second?
No.
Mr. Stevens? Mr. Stevens, can you look at me for a second? Does that feel sharp or dull?
I just want Mary.
They're never going to think I did a complete neuro exam.
In an older person, inability to cooperate with the physical exam is a physical sign. It tells us the person has reduced attention.
You tell me.
Mr. Stevens, really quickly, sir.
You didn't tell me.
Just really quickly, does that feel sharp or dull?
Is that Mary?
Sir, can you look at me for 1 second? Just really quickly, sir. Can you, Mr. Stevens?
Reduced attention, particularly if it's sudden in onset and fluctuates through the day, suggests delirium. In a patient with delirium, there are a few things you should and should not do. You should aim to confirm that delirium is present using the Inouye et al. Confusion assessment method. Find out how long they've been in their present confused or disorganized state. Find someone who knows them and ask them when did this start or when were they last themselves. Establish the baseline. Are they normally cognitively intact or do they have a history of dementia or memory problems? Clarify the fluctuation. Does this confusion seem to come and go throughout the day or night? Is this new? Examine for inattention. Can you count backward from 20 by twos? While they're doing this, tap a pen on the rail of the bed to distract them. If they can't do this, ask them to count from 1 to 10.
Okay, Mr. Stevens, I'm going to ask you to count backwards from 20 by twos. Okay, start at 20 and count down by 2.
20?
Okay.
18?
Mm-hmm.
16?
Yeah. And keep counting. Mr. Stevens?
I'm still looking for Mary.
Examine for altered level of consciousness. If they're anything but awake, alert and appropriate, i.e. agitated or somnolent, they have altered level of consciousness. Finally, check for disorganized thinking. Try a question like, what brought you to the emergency department today?
Mr. Stevens, I've got a couple questions for you. Sir, do you know why you're here today?
Where am I?
Sir, you're in the hospital. Do you know what brought you in here today?
Where's Mary left?
Okay, Mr. Stevens, we're going to try something a little different. Could you tell me what year you were born, sir?
Where's Mary?
The remainder of your physical exam should therefore be dedicated to trying to objectively determine abnormalities. Examples include not moving a limb spontaneously or prompted, guarding on the abdominal exam, fever or other abnormal vitals, skin rashes, ulcers, etc. What should you not do? You should not rely on subjective information from the patient, like, does this hurt or is this sharp or dull? You should not argue with the patient. You should not assume that when you come back with your staff person in an hour that they will be in the same state they are now. Because it is so distressing to patients and their families, knowing how to manage delirium can be one of the more satisfying experiences as a physician.